Good evening, everybody. So this is our fourth episode of Diabetes Crossroads. We are going to have today a speaker from outside Kerala also. Usually we have speakers from Kerala. This time we have also decided to invite Dr. Aravinda Jagdisha. He is there. He is going to talk on hypoglycemia. And we have now Sunil Prashobh, who will be dealing with acute metabolic complications other than hypoglycemia, probably hyperglycemic and other acidotic episodes. I think probably then we have some panel discussions as well beyond that. Now I'll request Dr. Prashant to take over and proceed with the functions. The program. Thank you very much.
Thank you, Suresh sir, and good evening, one and all. Good evening once again to the next episode of Diabetic Crossroads, which is a monthly online educational series which is done by the Kerala chapter of RSSDI. We have had very good response to the previous 3 episodes, so we are continuing with the next episode. Every time we are coming up with newer topics in diabetes. This is not a place where we are discussing the latest or the newer developments. We are just trying to refresh the known facts in diabetes and updating ourselves with the changes which have happened in the management of diabetes with respect to the basic management of diabetes. So this time we are going into the acute metabolic complications of diabetes. We have spaced the program in such a way that there will be 2 topics on the important topics like hypoglycemia and acute metabolic complications of acute complications like DKA and HHS. And next we will be having a panel discussion. I invite Dr. Chandri Madam, the chairperson of RSSDI Kerala chapter, to say a few words before we start the topic and the discussion.
Good evening, and as in the previous sessions, I am sure this is also going to generate a lot of interest and discussion, and this is actually giving us a direction to do the best for our patients with regard to our day-to-day management. And I'm happy that we have Dr. Vijay Kumar to lead us this program. And I invite all the speakers who have joined this program and also all those who have joined us today for making this a big, continuous, ongoing platform of discussion and learning. Over to Prashant for continuing the session. Thanks all the speakers for joining for today's program. Thank you so much.
Thank you.
So, thank you, Madam. So, as I said, we will be having 2 talks on the acute complications of diabetes, and we will have a panel discussion. Before that, the introduction to the topic and the context setting will be done by Dr. G. V. Kumar, who is the chairman-elect of RSSDI Kerala. And he's also one of the senior-most diabetologists in Kerala. Dr. Vijay Kumar sir does not need an introduction to anybody in Kerala and in this part of the world, because he has been one of the doyens in diabetes care in central Kerala, and especially with his interest in the management of diabetes food. He's one among the very few physicians who has keen interest in the management of diabetic food, and we have seen him save thousands of patients with very bad diabetic food get okay and get their limbs back in good condition. So I invite Vijay Kumar sir to give an introduction to the topic and set the tone for the rest of the meeting.
Thank you, Dr. Prashant, for the very nice introduction. I should congratulate the office bearers of RSSDI for having this novel idea of a monthly program to educate the ground level people who manage the diabetes in a day-to-day basis, rather than going for high-flying scientific material. So this type of interaction will be much needed for our state, I think. So regarding this topic, acute metabolic complications in diabetes, actually, as a person who is in managing diabetes for the last 40 years or so, my contention is that the acute complications actually, especially the DK and the HSS, and especially DK is the incidence is coming down over the years. Maybe because of more awareness about the management of diabetes among the public, and also the awareness among the healthcare professionals regarding the proper management of diabetes. The prevalence of DK definitely is coming down, I think. But the hypoglycemia definitely is on the rise, maybe because of more enthusiastic management. That may be that is on the other side. So regarding these two complications, actually DK, as we have ketoacidosis, actually is basically a complication which usually occurs in type 1 diabetes. Up to 30% of type 1 diabetes is diagnosed with when they present with diabetic ketoacidosis. But this is very comparatively rare as a presentation for the first time in type 2 diabetes. Up to 10% of type 2 diabetic patients can present with diabetic ketoacidosis. But the problems in management, actually the cost of management when a patient present with diabetic ketoacidosis, especially in a country, in a state country like India, is enormous, because majority of these patients may have to be hospitalized for some time. I mean, maybe in the ICU, very close monitoring may be required. And also, but so that brings us to how it should be. The question is how it should be prevented, and how it should be detected at the earliest time and managed at the right time with the right setting. So the high expenditure is a thing. So we have to find out the cause. Usually the cause is insulin omission, infections, pump failure in type 1 diabetes, etc. So I'm not going into details of all that. But for hyperosmolar hyperglycemic state, or HHS, is a complication basically of type 2 diabetes. And also lactic acidosis. Although I have not seen lactic acidosis cases. Maybe we may be missing. I may be missing that for the last several years. So these are complications basically of type 2 diabetes, but they also require very close monitoring and management in a very in an ICU setup, at least in the initial stages, because several electrolyte disturbances will be associated with all these problems. So all the three requires very close monitoring and treatment at the right time. And also regarding hypoglycemia, actually in type 1 diabetes, it may be up to 30% per 30 per 100 per patient years. That may be the incidence. But in type 2 diabetes, actually it is comparatively less, especially mostly it happens in patients on insulin, and also in the presence of renal dysfunction. So to discuss all these things, actually we have two eminent speakers, Dr. Sunil Prashop and Dr. Aravinda. They will be talking on these subjects. I think these acute complications, metabolic complications in diabetes, because every practicing physician or the general practitioner should be aware of these complications and should be able to detect it at the early time, and because it is eminently manageable at any level of hospital, so that is the importance of it. With these introductory remarks, I hand over the session to Dr. Prashant to continue with the discussions. Over to you, Prashant.
Thank you, sir, for that wonderful insights on the acute complications of diabetes. So we will straight away move to the first topic of discussion. The speaker for the first, other than Dr. Sunil Prashop. Dr. Sunil is a well-known figure in the field of internal medicine and diabetes in this part of the world. And Dr. Sunil is currently working as the Professor of Medicine and Diabetologist at Government Medical College, Kollam. And he had his MBBS and MD General Medicine Government Medical College, Trivandrum. He also holds an FRCP, FCCP, FIAMS, and PG DHSC in diabetology from the Johns Hopkins University. And he is an invited speaker for various conferences, and he has got the ability to give the topic a very lucid and very clear-cut presentation. And I have listened to many of his lectures, and I have been co-speaker along with him for many of the meetings in the past few years. He also has got publications in national and international journals. So I invite Dr. Sunil Prashop to talk on the topic of diabetic ketoacidosis, hyperosmolar hyperglycemic state, and lactic acidosis. Over to you, sir.
Shall I share?
Yes, sir. Yes, sir.
Host a disabled participant.
Yes, sir. Suresh, sir. Sharing rights on the transfer.
നിങ്ങൾക്ക് ചെയ്യാൻ പറ്റുമോ അത്?
ഇല്ല സാറിന്റെ അവിടെ നിന്ന് ചെയ്യാൻ പറ്റുമോ?
1 minute. പേരുണ്ട് കുറെ ആൾക്കാർ വന്നു. അയ്യോ സോറി. അയ്യാ, it is come. No, that was there.
Sir, മറ്റേ participant screen sharing അതൊന്ന് enable ചെയ്യണം sir.
1 minute. Participant screen sharing.
Dr. Sunil.
Settings in.
നാല് എല്ലാ സ്പീക്കറെയും കോഹോസ്റ്റ് ആക്കിയാൽ മതി. എല്ലാ സ്പീക്കറെയും കോഹോസ്റ്റ് ആക്കിയിട്ട്
പോസ്റ്റ് ഓഫ് റെക്കോർഡിംഗ് ഹൈഡ് സബ്സ്ക്രൈബ് right, Sunil is there. Now you can do that. You can do that, Sunil.
Okay.
Yeah. Sorry.
Sir, is it?
Okay. Can see that.
Yes, sir. It's okay.
Okay. First of all, let me extend my sincere thanks to the Kerala chapter RSSDI for this invitation and the opportunity. Chandri Madam, Suresh Sir, Prashant, Vijay Kumar Sir, and Vijay Kumar Sir for that introduction. So again, one another thing is my close friend Dr. Aravinda is also here to share the talk with him. Is a fantastic opportunity. So I will be dealing with the aspects like the diabetic ketoacidosis, hyperosmolar hyperglycemic state, and lactic acidosis. So as we all know, diabetes is growing in epidemic proportions. It's just growing in epidemic proportions such that we may have to face so many complications. And when it comes to the complications in diabetes, there are acute complications and there are chronic complications. When it comes to acute complications, the most important one are the infections and then the hyperglycemic emergencies. The hyperglycemic emergencies are diabetic ketoacidosis, hyperosmolar hyperglycemic syndrome, hypoglycemia, and lactic acidosis. Hypoglycemia will be dealt by Dr. Aravinda. Now, coming to diabetic ketoacidosis. Diabetic ketoacidosis is a state of metabolic decompensation which occurs as a consequence of severe insulin deficiency. And the triad of diabetic ketoacidosis is hyperglycemia, ketosis, and metabolic acidosis. Now, the diabetic ketoacidosis is being differentiated into mild, moderate, and severe, basically based on the arterial pH and bicarbonate. The moderate and severe diabetic ketoacidosis is very dangerous and they do need admission and intensive treatment. Now, if you look at the precipitants of diabetic ketoacidosis, infection and omission of insulin are the most important precipitants. The common precipitating factors include myocardial infarction, cerebrovascular accident, pancreatitis, alcohol intoxication, trauma, drugs. So all these, along with infections, are the common precipitating factors. Now, if you look at the pathophysiology of diabetic ketoacidosis, what we should understand is there is an absolute deficiency, absolute insulin deficiency happening in diabetic ketoacidosis. That is most important point, absolute insulin deficiency. Insulin, we all know, is an anabolic hormone as well as an anti-catabolic hormone. Why we say anti-catabolic hormone? Because it inhibits lipolysis. So when there is absolute deficiency of insulin, there is enhanced lipolysis. So there is increased free fatty acid form, and these free fatty acids are taken to the liver where ketogenesis happens, and this leads to acidosis. On the other hand, due to the inefficiency of the insulin, there is an increased counter-regulatory hormones, like glucagon, cortisol, and other such types of hormones. And this causes enhanced glycogenolysis and increased gluconeogenesis. This causes hyperglycemia. There is dehydration, loss of osmotic diuresis, decreased GFR, shock, and in some patients even renal failure can happen. So the most important point that we should understand regarding DK is there is absolute insulin deficiency along with increased counter-regulatory hormones. The important signs and symptoms of DK are majority of these patients will be presenting with hyperglycemic symptoms like polyuria, polydipsia, polyphagia. And many of these patients will be having acidotic features also, like the Kussmaul's respiration, respiratory alkalosis. Some of them may have smell of acetone in the breath. Variety of symptoms can happen in this group of patients. Even patients can present with abdominal pain or like an acute abdomen. All of us know all these things. Now, what are the important investigations? Of course, we know the blood glucose level. It is often more than 250 milligram percentage. The urine ketone bodies will be strongly positive. The bicarbonate, when you do the ABG, the pH will be 6.8 to 7.2, less than normal pH. The bicarbonate will be reduced. The electrolytes abnormalities are another very, very important thing. The sodium, most often there is a hyponatremia, and this is basically due to the dilutional hyponatremia. Potassium also, various abnormalities. Due to the acidosis, the H+ ions shift into intracellularly and the potassium comes out of the cell. So initially, due to the acidosis in DK, there may be a false high potassium levels. But as the treatment starts, once you give insulin, there will be hypokalemia. So various metabolic abnormalities like the sodium, potassium, reduced phosphate, even the creatine, there is a mild azotemia due to the dehydrations. So this is another very important concept when you're doing an anion gap. Anion gap, all of us know it is the sodium minus chloride plus bicarbonate. Now, what happens is the keto acids, the organic acids, they are organic acids. The keto acids, they buffer with bicarbonate. So the bicarbonate is reduced, not available for in this anion gap. So the anion gap increases. So basically, diabetic ketoacidosis is a high anion gap metabolic acidosis. That is the most important point. High anion gap metabolic acidosis. And that is basically due to this keto acids buffering with bicarbonate. So this is what often happens. Many of these patients will be doing well, and they will come in contact with the precipitating events. Then suddenly the symptoms of hyperglycemia starts. The patient will go in for Kussmaul respiration, altered sensorium, cardiovascular collapse and coma, and death. So this is the usual picture that we usually see. And what are the goals of treatment of DK? The most important thing is the intravascular volume expansion, and this we need to correct. So we need to address many issues like the correction of fluid deficit, electrolyte problems, the acid-base balance. We should give insulin, and also we should address the precipitating cause. Now, as I have already told you, the moderate and severe ketoacidosis do need attention. They need to be admitted in ICU and taken care well, because many of these patients cannot retain oral fluids, cannot take oral fluids. Patients will be in altered mentation. So preferably in a high definition unit ICU, they need to be admitted. So the principles of treatment of DK are the fluids, insulin, then observation of the vital signs, the urine flow chart, the infusions, the glucose, pH, electrolytes, all these should be documented. And this is what we usually do, the IV fluids, insulin, potassium, bicarbonate. Let us take one by one. IV fluids are the cornerstone of management of diabetic ketoacidosis. Always determine the hydration status. And if the patient is in cardiogenic shock, the thing is different. We need to have a hemodynamic monitoring. And if the patient is in a hypovolemic state, we can give normal saline. And if the patient is having a mild hypotension, always evaluate the corrected sodium level. And if the sodium is low, we can start on normal saline. And if the sodium is normal or high, we may give a half normal saline. So this is what we usually do in our clinical practice. All of us know the decay takes hours or days to develop more rapidly rather than the HHS. Decay develops more rapidly. And the most important vehicle that we use, the IV fluid that we give, is the normal saline. In the first 1 hour, we give 1 liter, 2 hours, we give 1 liter, and the next 4 hours, 2 liters. So at least in the 3 to 4 hours, we need to give 3 to 4 liters. And this, most of the patients will be having a deficit to the tune of 6 liters. And this deficit need to be corrected over a period of 24 to 48 hours. And once the blood glucose comes down below 250 milligram, you should change the IV fluid to dextrose in normal saline. Now coming to the insulin therapy, the most important thing is the IV route. IV route is the most preferred route in diabetic ketoacidosis, but some say that we can even use IM for mild cases. But every one of us prefer IV route because we all know basically we are giving IV is to correct the acidosis. Initially, a bolus of 0.15 unit per kilogram has given us IV bolus and then given us infusion to the tune of 0.1 unit per kilogram per our IV infusion. Then we should look for the fall of blood glucose. At least in the first hour, the blood glucose should fall to the tune of 10% or 50 to 70 milligram per hour decrease in blood glucose should be there. If such a fall is not there, we may have to increase the dose of insulin to 0.2 units per kilogram per hour. So once the blood glucose reaches 250 milligram percentage, what we should do is, as I have told you, we should change the fluid to a 5% dextrose in half normal saline, and always try to attain a blood glucose in the range of 150 to 200 milligram percentage. Very, very meticulous monitoring of this blood glucose hourly. Electrolytes, at least 2 or 3 hourly electrolytes should be monitored. ABG once in a while. All these are very, very important. The most important point that all of us should understand is the transition from IV fluid to subcutaneous insulin. When can we transit from IV to subcutaneous insulin? Once the patient can eat, once the patient can take oral feeds, once the acidosis gets corrected, once the blood glucose reaches 250, 200 milligram percentage, we can transit from an IV route to a subcutaneous route. But the most important underlying point is there should be an overlap period. Once you start a subcutaneous, you should continue the IV infusion at least for 1 to 2 hours. Otherwise, there is always a danger of rebound ketosis and all these problems bound to happen. Now, why we are giving 5% dextrose when once the blood glucose reaches 250? It is basically given to avoid hypoglycemia. As I have all of us know, once hypoglycemia happens during the treatment, it is very dangerous because once the blood glucose goes far below, again, there is going to be a counter-regulatory hormone rise. And again, the rebound ketosis and all the metabolic complications are bound to happen. So this is a very, very dangerous situation. So regarding the treatment of insulin, these are the points that we should always keep in mind. All the DK patients need insulin. It takes longer to reverse acidosis than to treat hyperglycemia. And the regular insulin is the one that we should always use. Even the newer insulin analogs like Lispro and Aspart is now being said that that can also be used. But most often, all of us use a regular insulin. And always a continuous low-dose insulin infusion is the one which is being used as an intravenous insulin pump. That is the most preferred method, basically because the insulin pump, if you are giving through the continuous infusion, it causes a reduced incidence of hypoglycemia, hypokalemia, and there is also a reduced risk of cerebral edema. As I have already told you, some says that even in mild cases, we can preferably give intramuscular insulin. But these do have certain disadvantages like patient discomfort, lack of predictability, and this cannot be used, especially if the patient is having a shock or cardiac failure for that matter. So this is another very important aspect that all of us should understand. Now, while we are treating a DK patient, all of us know the beta hydroxybutyric acid, the conversion happens. The beta hydroxybutyric acid, during the conversion to bicarbonate, in between it forms the acetoacetate and acetone, and then only bicarbonate is formed. This acetoacetate is the one which we are testing in urine ketone. And the acetone is the one which we are looking in the serum ketone. So during the treatment, this conversion is definitely going to happen. Most of the time we get fooled because when we look the urine ketones may still be positive and the blood glucose might have come down. The ABG might have settled, but the urine glucose still remains as positive. This is the area where we get often fooled. And this is basically due to this conversion happening. So never look at the urine ketones for after 2 or 3 days. The most important thing, what is being said is the anion gap. Anion gap, if it is less than 12, we can say that our DK is adequately controlled. Next is a very, very important concept of potassium. I have already told what are the changes that is happening in potassium. In a case of acidosis, when there is acidosis, what happens is hydrogen ions shift intracellularly, and at the same time, potassium is shifted outside into the extracellular fluid. So there is a false high potassium in the initial stages. But once the treatment starts with insulin, the insulin pushes the potassium intracellular. So once the treatment happens, always you are bound to get hypokalemia. This is very, very dangerous, and you should always be the lookout for that. So regarding the potassium, the most important thing is if the serum potassium is less than 3.3, always give potassium. And if the potassium is between 3 to 3.5, 3.3 to 5, then also you may give potassium in such cases. But if the potassium is very high to the tune of more than 5, no, never give potassium. So always the target potassium range would be to the tune of 4 to 5 millimoles. Another very important concept is the acidosis, whether we need to give bicarbonate in all cases of DK. This is a very, very controversial area also. Now, all of us know that acidosis is a very, very dangerous thing because why? It causes cardiovascular depression, causes respiratory depression, it causes various types of arrhythmias. But the most important point is we cannot treat all acidosis with the bicarbonate. If you are giving bicarbonate, several problems can happen. If you treat all the patients with bicarbonate, there is always an increased incidence of hypokalemia happening. Another important thing is there is a paradoxical CNS acidosis and CNS depression can happen. Another very important thing is when you give bicarbonate, there will be shift of the oxygen dissociation curve to the left, and there will be decreased tissue delivery of oxygen happening. So if the patient has got a pH of more than 6.9 to 7, don't give bicarbonate. That is the thing that is being told. If the pH is less than 6.9 or 7, then you should definitely give bicarbonate. Bicarbonate, sodium bicarbonate, we can give 100 millimoles, dilute in 400 ml water and infuse at a rate of 200 ml per hour, along with potassium, because as we know, as I have already told you, when you are giving a bicarbonate, there is a chance of hypokalemia. So along with bicarbonate, you should add potassium also. So let us see what are the complications of diabetic ketoacidosis. There are several complications are always prone to happen. The most important is the infection. There is a arterial thrombosis because of the increased hemo concentration, hyperosmolarity. Then the unrelenting shock. Shock is another very important thing because many of these patients I have told there is going to be dehydration and shock can happen. Another important complications are the ARDS happening, the acute respiratory distress syndrome. But one of the most important complications, which is always being said along with diabetic ketoacidosis, is the cerebral edema. The cerebral edema is a very, very dangerous complication, especially in children. And the cerebral edema can happen at the time of DK and also especially during the treatment period. And this is basically due to the CNS and peripheral osmotic disequilibrium state happening. And often during our over rehydration, when we treat more with IV fluids, what happens, or the blood glucose comes down very quickly. There will be shift of fluid from extracellular to intracellular space, especially the CNS cells, the brain cells, and cerebral edema can happen. This cerebral edema is very, very bad, especially if it happens to children, because the mortality is very, very high. It is rather less common in adult population. So what are the general care that we should always look when we are treating diabetic ketoacidosis? Always look for the precipitating cause. I have already told you the infection, the myocardial infarction, all these things we should address. If there is hypotension, it usually responds to an adequate fluid replacement. If the patient is a cardiac patient, you can better have a central venous pressure monitoring. ECG before giving potassium and to document the hyper and hypokalemia is a very, very important tool. If cerebral edema happens, you can give mannitol, dexamethasone. Then brain imaging is another important thing. If you happen to see very, very altered sensorium and other focal neurological deficit, you can treat adult respiratory distress syndrome, the thromboembolic complications, mechanical ventilation if needed. So let us discuss some of the common pitfalls, potential pitfalls that can happen in the management of decay. As I have already told you, the smell of acetone is present in many of these patients, but it may not be apparent in all patients because many people are anosmic to acetone. Now, when it comes to the fever, if fever per se does not happen in decay, if fever is seen, always think of infections. But there are certain instances in which fever may be absent in the presence of infections also, and that is basically due to the peripheral vasodilation, which causes cooling. When it comes to the total count, the blood leukocytes, usually non-specific elevation of total count can happen, and this is due to the catecholamines, the pro-inflammatory cytokines. But if the total count is very much elevated, more than to the tune of 20-25,000, always think of infection. The sodium I have already alluded. There is always the possibility of dilutional hyponatremia, so there is a chance of reduced sodium. The potassium I have already told. The pre-renal azotemia I have already told. And when it comes to the ketostic texting, may show negative or trace result when it is associated with the lactic acidosis or an alcoholic ketoacidosis. When both of these conditions they coexist with the diabetic ketoacidosis, it may show a negative result. Another thing, the ketosic reaction may become temporarily stronger during the treatment. I have already very clearly alluded that during the treatment, the urine ketones may be positive, but don't get fooled by that. The transaminase, always there is a chance it can get non-specifically raised. Now, coming to the second very, very important aspect, the hyperosmolar hyperglycemic state, or previously it was called as HOG, hyperosmolar non-ketotic state. And it is very commonly seen in patients with type 2 diabetic patients. Many of the patients are elderly, they omit insulin or they don't take OHAs, persons living in nursing home, living alone. Elderly patients are the most important one which we see. The most important aspect is too little insulin, and they do have a common precipitants like acute stressors, renal failure, hyperglycemia-inducing medications. The important 5 I's, they are the stressors, and they include infection, infarction, insulin non-compliance, then ischemia and intoxication, especially the alcohol and drug. So all these, the stress and the precipitating factors are a very, very important point in HHS. I have very clearly explained the pathophysiology behind decay. Now, when you see HHS, what we should understand here, there is only relative insulin deficiency, not absolute. Here it is relative insulin deficiency. Along with that, there is a counter-regulatory hormone rise also. So what happens is there is an increased hyperglycemia, there is an osmotic diuresis, severe dehydration. The most important thing is the increased osmolarity, the hyperosmolarity that is happening in many of these patients. And the most important symptoms are basically due to the hyperosmolality, like the decreased mentation, the focal neurological signs. All these are basically due to the hyperosmolarity happening in HHS patients. And the most important thing is HHS is usually seen in type 2 diabetic patients. So apart from the routine investigations, the most important thing that all of us should do, we should calculate the serum osmolality. And the serum osmolality is most often elevated to the tune of more than 3 20 milliosmoles per liter. And this, hope everyone knows this formula for calculating serum osmolarity. So the main underlying abnormality of HHS is the hyperosmolarity driven symptoms and signs. So when it comes to the treatment, the primary goal is the rehydration to store the plasma volume and correct the electrolyte deficit. The management is almost similar to the DK management, the IV fluids, the insulin, and potassium. Now, when it comes to the replacement, what happens in a patient, depending on the patient's state of hydration and cardiovascular state, we can start whether it is the normal saline or the half normal saline, depending upon the sodium concentration. We need to hydrate elderly patients with caution. We need to hydrate elderly patients with cardiac failure or CKD very, very cautiously. In such group of patients, it should be ideally CVP monitored. The insulin guidelines are almost similar to the diabetic ketoacidosis. Most often, we may require lower doses, especially in insulin-sensitive patients. So the essential difference, all of us should understand the differences between diabetic ketoacidosis and HHS is in blood glucose. If you look at the blood glucose, it comes to the tune of more than 250 milligram in DK. Acidosis, ketosis present. The water deficiency is to the tune of 6 liters. It develops more rapidly than HHS. Most often it is seen in type 1 diabetic patients. But if you look at the HHS, the blood glucose level is very high, often more to the tune of 600 more. The serum osmolarity is more than 320. More water deficit, that's 9 liter water deficiency is often present. It develops slowly as compared to DK, most often seen in type 2 diabetic patients, and the mortality comes to the tune of 15%, whereas the mortality in the DK patient is only to the tune of 5%. Now, coming to the third important aspect, the lactic acidosis, which is not a very, very important as that of the other two. Now, what we should understand regarding lactic acidosis, there are two types, type A and type B. And type A is basically an anaerobic type, and it is basically seen in patients with shock, heart failure, asphyxia, carbon monoxide poisoning. But the most common one that we see is the type B, because type B is usually associated with the diabetes, the renal failure, hepatic failure, malignancy, and drugs like biguanides. So these are the clinical features that we see in patients with lactic acidosis: cyanosis, cold extremities, tachycardia, hypotension, altered mentation, and hyperventilation. The lab findings are very important. So when you do an ABG, there will be a high anion gap metabolic acidosis with a serum lactate of more than 5 millimoles. Now, when it comes to the treatment, hydration forms the most important part of treatment of lactic acidosis with a judicious intravenous bicarbonate therapy. In severe cases, we may have to resort to even dialysis. Two important aspects which I like to highlight at this point. During our management in DK and HHS, despite the optimal fluid therapy and insulin therapy, if still there is a refractory metabolic acidosis with a very high anion gap to the tune of 30, 35, always suspect a associated lactic acidosis in patients with diabetic ketoacidosis and HHS. Another very important concept, which again I want to highlight, is the metformin and lactic acidosis. All of us has been studied. There is a high metformin is notorious for lactic acidosis, but this complication is a very, very rare complication. Metformin associated with lactic acidosis is a very, very rare. Previously, the fenformin, all of us know, the fenformin was 50 times more amenable for lactic acidosis, but now that is no more there in the market. But metformin is a very, very important thing. We should always keep in mind that lactic acidosis is a possibility. And lactic acidosis associated with metformin happens whenever you use metformin in contraindicated patients in very high dose. If it is contraindicated, you should never use. If you use, you can always come across with this problem. To diagnose that, we should always rule out diabetic ketoacidosis. We should rule out uremia. And in such patients, if you have a high anion gap metabolic acidosis, always think the possibility of a metformin associated lactic acidosis. So all the complications, if you take together, the diabetic hyperglycemic comas you see, the most important things, the hypoglycemia, the most important, blood glucose will be low. In all others, the blood glucose may be high. The ketoacidosis is prone to produce ketosis and acidosis. If you look at the pH, probably the hypoglycemia is normal. In all others, pH is maybe low. Sodium levels, hypoglycemia not much. All others, the sodium abnormalities can happen. The lactic acidosis will be high. In lactic acidosis, the serum lactate will be high. The blood volume abnormalities, the dehydration, the hyperosmolality, all these are most prominent in hyperosmolar, hyperglycemic states. Before winding up, let me give some clinical pearls regarding the management of the DK and HHS. Now, when you are treating with IV fluid, I have already told the IV fluid is the cornerstone of management of DK. So when we can say that your IV fluid therapy has become a success, you should always look three factors. One is the blood pressure, two is the urine output, three is the clinical examination. Based on these three aspects, you can judge the success of your IV fluid therapy. The second point is shift or the transition from IV to subcutaneous insulin. I have already told the IV insulin we are giving basically to correct the acidosis. So we need to transit from IV to subcutaneous once the patient can take oral feeds, once the blood glucose has come below 200 milligram percentage, the acidosis has corrected, then we can transit. Always remember regarding the overlap between IV insulin and subcutaneous insulin, at least for a period of 1 to 2 hours. The most important thing is the urine ketone bodies. The urine ketone bodies always lag behind the clinical recovery because of the conversion, which I have already explained. So never get fooled by that. Another, if your treatment is not adequate, there is always a chance of rebound ketosis, and that can be very, very dangerous. Now, if you cannot do an ABG, it is very well said that even VBG is sufficient to look at the pH because the error happens to a very, very low amount, 0.026. That is the error which is being said. So if ABG is not available, we can very well do a VBG. Then the prognosis of DK actually depends on two main factors. One is the acidosis, how much time the patient is remaining in acidosis. And another thing is the hypotension. These two factors is basically going to determine the prognosis of a DK patient. Another important aspect, all of us know the euglycemic ketoacidosis is nothing but the blood sugar will be normal, but the ketosis will be there. And this is most often associated with an SGLT2 therapy. It is one of the side effects which is being said for SGLT2 therapy. And it is basically due to the reduced insulin, decreased glucose, so insulin comes down, and then the enhanced lipolysis and ketosis happening. So just to wind up and summarize what I was trying to convey in the last 20 minutes was acute complications are on a rise. These are very, very dangerous. The hyperglycemic emergencies include DK, HHS, hypoglycemia, lactic acidosis, and infections. When it comes to DK, it is most commonly seen in type 1 diabetic patients, develop rapidly, acidosis and ketosis are there. When it comes to HHS, most often seen in type 2 diabetic patients, it develops much more slowly and the mortality is very high because many of these patients will be having several comorbidities. Dehydration, hyperosmolality is very, very high. When it comes to the management, the pillars are the IV fluid, the insulin, electrolyte imbalance, and also the stressors management or the precipitant factors management is very important. Now, when it comes to complications, the infections, the ARDS, the rebound ketosis, cerebral edema, arterial thrombosis, hypotension, shock, all these are the major complications. But the most important thing is all these complications are preventable by proper education, by treating the patient. When you discuss the patient regarding the sick day rules, never skip insulin, never skip OHA. So proper education and the easy awareness and making the patient aware about all these complications. Many of these complications we can prevent if we judiciously discuss with the patients. When it comes to the mortality, I have already told the HHS has got a 15% where the DK has got only a 5%. If lactic acidosis happens, the mortality is even more. So thank you for this patient listening and very, very sincere thanks to RSSDI Kerala chapter for this fantastic opportunity. It was a pleasure talking to you.
Thank you, Sunil sir, for that excellent lecture. As I said in the beginning, the presentation was so clear and lucid, and we could get a lot of points from your presentation. So we will quickly move on to the next topic. Can you stop sharing the screen, sir? Yeah. Presenting the next topic, I would like to introduce Dr. Aravinda Jagdisha, who is a well-known figure, who is the Kannadiga superstar in diabetology. And Dr. Aravinda Jagdisha is currently the proprietor and chief diabetologist at Dr. Aravind's Diabetes Center in Bengaluru. He has got vast experience of working in various hospitals in the UK, especially in the field of diabetes and endocrinology, one of the few persons with an MRCP and triple FRCP. He has got plenty of awards like the Times of India Healthcare Achievers Award in the field of diabetes and endocrinology, Bengaluru's highest civilian award, Nada Prabhu Kempagowda Award for his work in the field of diabetes in 2018. Received the Diabetes Awareness Initiative Award at the Diabetes India Conference in 2017, over 75 conference presentations, 30 publications, and he's also involved in clinical trials. He's an eminent speaker at the national and international level, and at various conferences and webinars, and one of the most recent one was the International Diabetes Federation, where he was also one of the organizing committee members. He was a past president of RSSDI Karnataka chapter 2018 and 19. So it's my pleasure to welcome Dr. Aravinda to join the session and start giving his talk.
I'll share my slide.
Yes, sir.
Please.
Are you able to see my slides?
Yes, very much.
Yeah. So good evening, everybody. At the outset, I thank Kerala RSSDI team for inviting me to be a part of this monthly meeting of Kerala RSSDI. In fact, during my presidency in 2018-19, I had started this in Karnataka as well, where we did 12 monthly CMAs physically. So at that time, it was a super hit and very well appreciated across India. And it is nice to see all the same things going on across India, so that the knowledge of diabetes is shared among all of us, and the latest concept of diabetes is shared among all the treating diabetologists across India. So first of all, I thank Dr. Prashant Shankar for inviting me for this webinar. And I also thank Dr. Chandini ma'am, Dr. Suresh Kumar, Dr. Hari, Dr. Anita Nambiar, and Dr. G. Vijay Kumar, and my friend, my co-speaker today, who had a very good lucid presentation from Dr. Sunil Prasad. So to continue on my topic, another interesting talk, another important talk, that is hypoglycemia, diagnosis and management, and the preventive strategies. First of all, greetings to all of you from Bangalore. So this is the table of contents of my talk today. First of all, what is hypoglycemia? Risk factors and clinical presentation, diagnosis of hypoglycemia, preventive strategies for hypoglycemia, and management of hypoglycemia. So hypoglycemia is one of the most difficult aspects of diabetes management. I'm sure all of us will agree. Definition from ADA, if you take any abnormally low plasma glucose concentration that exposes the subject to potential harm with a proposed threshold plasma level value less than 70 milligram per deciliter. That is less than 3.9 millimole per liter. So this is the definition we should all remember to say a person having hypoglycemia. If you take the classification of hypoglycemia, there are three levels, that is level 1, 2, and 3. Level 1 is the glucose less than 70 and more than 54 milligram per deciliter. Level 2 is glucose less than 54 milligram per deciliter. Level 3, a severe event characterized by altered mental and or physical status requiring assistance for treatment of hypoglycemia. So these are the three levels of hypoglycemia we should remember. If you take this hypoglycemia counter-regulatory hormones and action, we know that the first one is the insulin, the most important one, secreted from the beta cells. It suppresses the hepatic glycogenolysis and hepatic gluconeogenesis, and it suppresses the glucose production. That is the hypoglycemia counter-regulatory action. Glucagon, once again from the alpha cells of pancreas, it stimulates the hepatic glycogenolysis and gluconeogenesis. Third one is the epinephrine. It is secreted from adrenal medulla. It suppresses the hepatic glycogenolysis and hepatic gluconeogenesis, stimulates renal gluconeogenesis, limits glucose clearing in peripheral tissues, suppresses insulin secretion. Fourth one is the cortisol, that is the growth hormone, secreted from adrenal cortex, that is somatotrophic cells from the anterior pituitary. It increases glucose production, limits glucose clearance, effect is delayed for hours. If you see in this slide, the glycemic threshold for secretion of counter-regulatory hormone, starting from the left-hand side, upper side of the slide, you can see at 4.6 millimole per liter, there is an inhibition of endogenous insulin secretion. At 3.8, there's a counter-regulatory hormone release, that is the glucagon and epinephrine. 3.2 to 2.8, that is the onset of symptoms from autonomic neuroglycopenic. 2.4 to 3, that is neurophysiological dysfunction, that is evoked responses. At 3 millimoles, widespread EEG changes. At 2.8 millimoles, cognitive dysfunction, that is inability to perform complex tasks. And less than 1.5 millimoles, that is severe neuroglycopenia, there will be a reduced conscious level, convulsions, and coma. This simple slide we are showing at what levels of glucose the symptoms of varied symptoms of hypoglycemia occurs. If you take the prevalence of hypoglycemia, several large-scale clinical trials have demonstrated the incidence and prevalence of hypoglycemia in patients with both type 1 diabetes and type 2 diabetes. The rates of severe hypoglycemia are more common among older adults and those with chronic conditions such as CKD, CVD, CHF, depression, and higher HbA1c levels, as well as among those who are on insulin or who take secretagogues. So learning from DCCT trial, that is the Diabetes Control and Complication Trial, 1,000 episodes of loss of consciousness associated with hypoglycemia. Even with treatment, there are reported cases of long-lasting severe hypoglycemia leading to transient and even permanent cerebral damage. Hypoglycemia that is not reversed can progress from lethargy to coma and ultimately due to death as well. The percentage of severe hypoglycemic events in Acute Advance and VADT study, you can see in this slide. On the left-hand side, you can see the Acute. Nearly 16% of the patient had hypoglycemia in intensive glucose control arm when compared to the standard control arm. In the middle, you can see the advanced study. It is again 2.7% versus 1.5%. On the right-hand side, you can see the VADT study. 21% at the hypoglycemia in intensive glucose control arm when compared to the 9.9% standard control arm. So the most important thing is the mortality. There is an increased mortality has been observed in randomized control trials during more aggressive compared with the less aggressive glucose lowering therapy in patients with type 2 diabetes and in patients with hypoglycemia in intensive care units. The association has been thought to be multifactorial. Now coming to the risk factors and the clinical presentation. So hypoglycemia is both a clinical and a physiologic condition that is associated with increased morbidity and all-cause mortality in individuals with both type 1 diabetes and type 2 diabetes. The conventional risk factors you can see in this slide, this is an important slide where you are seeing the various conventional this one. The first one is the insulin or the insulin secretagogue. If the doses are excessive, ill-timed, or of the wrong type. Second one, exogenous glucose delivery is decreased as following missed meals and during the overnight fast with gastroparesis or celiac disease. Third one, glucose utilization and sensitivity to insulin are increased as during and shortly after exercise, in the middle of the night, following weight loss or improved glycemic control. Fourth one, endogenous glucose production is decreased as following alcohol ingestion or in liver failure. Next one is the insulin clearance is decreased as we see in renal failure. Last but not the least is the classical diabetic autonomic neuropathy. The risk factors indicative of hypoglycemia associated autonomic failure. You can see the degree of absolute endogenous insulin deficiency. This determines the extent to which insulin levels will not decrease and glucagon levels will not increase as plasma glucose concentration falls in response to therapeutic hyperinsulinemia. It is in part a function of the duration of diabetes. A history of severe hypoglycemia, hypoglycemia unawareness, or both, as well as a recent antecedent hypoglycemia, a prior exercise or sleep. The studies with a control group treated to higher mean glycemia consistently document higher rates of hypoglycemia in the group treated to lower mean glycemia. However, hypoglycemia can occur in individual with any HbA1c level. So what are the other risk factors? The most important one is the advanced age, tight glycemic control, renal insufficiency or end-stage renal disease, pregnancy, multiple diabetic medications, low diabetic knowledge, type 1 diabetes, insulin-dependent type 2 diabetes, previous hypoglycemia. These are all the other risk factors. This is an interesting slide which shows the putative mechanism of hypoglycemic unawareness. You can see from the top, what does the increased recurrent hypoglycemia causes? Increased GLUT1 activity leads to altered ventromedial hypothalamus sensing of glucose, leading to increased GABA levels in ventromedial hypothalamus. This leads to diminished autonomic response to hypoglycemia. This is the most important things which all of us should be aware of it. Why? Once there is a diminished autonomic response to hypoglycemia, there will be reduced sweating, part of glucagon production under autonomic control is reduced. There will be absence of palpitation, reduced production of catecholamines, and absence of tremor. So the patient is not aware of all these symptoms. So even there is an hypoglycemia is totally unaware of it. So the mechanism by which hypoglycemia may affect cardiovascular event, you can see from the center where the hypoglycemia is there. You can see at the top, it leads to inflammation, leads to the increase in the inflammatory markers like increased CRP, increased VEGF, increased interleukin-6. On the right-hand side of hypoglycemia, you can see it can lead to endothelial dysfunction and leads to decreased vasodilatation. On the left-hand side, you can see it leads to coagulation abnormalities, increased factor VIII, increased platelet activation, and increased neutrophil activation. At the bottom, you can see there is a sympathetic response, that is increased adrenaline, rhythm abnormality, hemodynamic changes leads to increased contractility and increased heart workload. This is how the mechanism of hypoglycemia may affect the cardiovascular events. So what are the precipitants for hypoglycemia? The most important precipitants is the drugs, mainly the insulin and the insulin secretagogues. There are others like sibenzolin, gatifloxacin, which we should remember, pentamidine, quinine, indomethacin. Next is the physiological one, that is the diabetic complications like gastroparesis. Next may be factitious like misuse of insulin or excessive alcohol consumption. Next is the endocrinopathies and malabsorption. Next is the autoimmune conditions like insulin autoimmune syndrome. The third one is not to be neglected, that is the psychological or psychosocial. There is a fear of hypo or hyperglycemia, denial, depression or other mental illness, and cognitive impairment. Signs and symptoms of hypoglycemia. I am sure all of us in this forum, we are well aware of it, because definitely we would have some other of the patient in our routine clinical practice. Just to recollect ourselves, like pallor, diaphoresis, tachycardia, blood vision, elevated blood pressure, palpitation, paresthesia. Then comes the neuroglycopenic signs and symptoms, that is difficulty in concentration, hypothermia, weakness, warmth, hunger, fatigue, motor impairment, slurred speech, seizures, loss of consciousness. Then comes the behavioral or mood signs or symptoms, that is the emotional ability, including anger, giddiness, tense, anxiety, irritability, feeling down, and teary. All these things are definitely seen as the signs and symptoms of hypoglycemia, which all of us would have seen in our patients. So now coming to the diagnosis hypoglycemia, it is the Whipple's triad. You can see on the right hand side what that the triad is. One is the low plasma glucose level, that is typically less than 70 milligram per deciliter. Signs and symptoms consistent with hypoglycemia. And the third one is the resolution of signs and symptoms of hypoglycemia followed an increase in plasma glucose level. So on the left hand side, you can see the triad is not entirely diagnostic, because it may be evaluated by factitious administration of hypoglycemic agents, by rare soft tissue tumors, or occasionally by reactive hypoglycemia. So the clinical syndrome of hyperinsulinism may follow one of two patterns or sometimes a combination of both. Next come the preventive strategies recommended by ADA 2022. You can see here the recommendation is the occurrence and risk for hypoglycemia should be reviewed at every encounter and investigated as indicated. Glucose approximately 15 to 20 gram is the preferred treatment for the conscious individual with blood glucose less than 70. Although any form of carbohydrate that contains glucose may be used 15 minutes after the treatment. If blood glucose shows continued hypoglycemia, the treatment should be repeated. Once the blood glucose or the glucose pattern is trending up, the individual should consume a meal or a snack to prevent recurrence of hypoglycemia. Then in the class E, the glucagon should be prescribed for all the individual at increased risk of level 2 or 3 hypoglycemia, so that it is available should it be needed. Caregivers, school personnel, or family members providing support to these individuals should know where it is and when and how to administer it. Glucagon administration is not only limited to healthcare professional, it can be any given by the paramedics as well. The insulin-treated patients with hypoglycemia unawareness, one level 3 hypoglycemic event, or a pattern of unexplained level 2 hypoglycemia should be advised to raise their glycemic targets to strictly avoid hypoglycemia for at least several weeks in order to partially reverse hypoglycemic unawareness and reduce risk of future episodes. Ongoing assessment of cognitive function is suggested with increased vigilance for hypoglycemia by the clinician, patients, and caregivers if impaired or declining cognition is found. So because older adults with diabetes have a greater risk of hypoglycemia than the younger adults, episodes of hypoglycemia should be ascertained and addressed at routine visits. For older adults with type 1, CGM should be considered to reduce hypoglycemia. So now coming to the management strategies, so it all depends upon the conscious state and degree of uh, cooperation of patients. You can see here, treatment of hypoglycemia, just this is a pictorial demonstration of what the ADA recommended. The first is 5 to 15 grams of fast acting oral carbohydrate. What is it? Like glucosate or sugar lumps, dextrosol, followed by biscuits and milk. Next, take quickly absorbed carbohydrates such as half glass of juice, 5 to 7 jelly beans, 3 spoons of honey or sugar, glucose that contains 15 grams of carbohydrate. Once the patient is stabilized, then you can go for a slowly absorbed carbohydrate, just like a sandwich, biscuit, a glass of milk, a piece of fruit. Retest the blood glucose after 15 minutes. Even if it is low, then you can give glucagon. It can be given as subcutaneous, intramuscular, or intravenous. However, you kindly note this will not work with alcoholics, elderly, and depleted glycogen store people. Then even if there is a continued conscious level is less, you can infuse glucose 10% solution. If not, then go for 50% solution. In a rare cases, octreotide is also used, which inhibits the release of insulin. This is used in the treatment of sulfonylurea-induced hypoglycemia. Only consider if it doesn't respond to dextrose. This is one of the treatment options. So what are the warning? The most important warning is persistent of an altered conscious level suggests there is an underlying pathology, either a stroke or a development of cerebral edema due to hypoglycemia. Then maintain plasma glucose at 7 to 11 millimoles per liter. If still there is a reduced conscious level, always contact the ICU, may consider mannitol or dexamethasone. If still it is a problem, then you can go for further evaluation like CT scan. 90% of the patients fully recover in 20 minutes. When hypoglycemia cause is identified and fully corrected, patient can be discharged after observation at the emergency department and appropriate follow-up. The most important preventive strategy is to know the causes of hypoglycemia, the imbalance between factor rising and lowering blood glucose level. So what are the factors causing increased blood glucose, like food, counter-regulatory hormones? What are the factors which cause a decreased blood glucose level, that is insulin or oral medication, or about the physical activity? The medication, that is overdosing of insulin or anti-diabetic medication, inadequate diet or the delayed or the missed meal, unsupervised exercise, heavy exercise, especially in type 1 diabetes. Sometimes what happens, patient with over enthusiasm by seeing some movies or some movie stars, they do exercise overly and they suddenly land up in hypoglycemia. Suddenly they see Kareena Kapoor and they want to do a diet exercise very sincerely. So they start dieting. All of a sudden they land up in hypoglycemia. So the education plays an important role in preventing hypoglycemia. So the long duration of diabetes causes complication. Example, the presence of autonomic neuropathy that causes hypoglycemia unawareness, and nephropathy causes decreased insulin clearance. Adolescents and children are unable to detect and treat mild hypoglycemia. Elderly leads to severe cognitive impairment. So always arrange follow-up having considered the following. Once the patient is just discharged, you have a discussion with the patient and their relatives. Why did this episode occur? Has there any been recent change of regime, other drugs, alcohol, etc.? Is the patient developing hypoglycemic unawareness or the autonomic dysfunction? Always be vigilant. Intensive diabetes management, that is the tight glycemic control, reduces long-term complications, but increases hypoglycemia risk and reduces a person's quality of life. Substance abuse like drug, alcohol consumption, increased insulin sensitivity, and reduced insulin clearance impaired hepatic neoglucogenesis by alcohol, impaired renal and liver function, weight loss, empty nest syndrome, that is alone and intelligent, attention-seeking syndrome. This may be also a problem. Patient with psychiatric issues like depression and mood swings. Next, the coronary artery disease and the infection. So the ADA recommendation is in older adults with type 2 diabetes at increased risk of hypoglycemia, medication classes with low risk of hypoglycemia should be preferred. Over treatment of diabetes is common in older adults and should be avoided. De-intensification or simplification of complex regime is recommended to reduce the risk of hypoglycemia and polypharmacy if it can be achieved with the individualized A1C target. Consider costs of care and insurance coverage rules when developing treatment plans in order to reduce the risk of cost-related non-adherence. So, ladies and gentlemen, take-home message from my talk today is the threat of hypoglycemia is one barrier to providing optimal glycemic control in the inpatient setting. Prevention is key in ensuring patient safety, identifying risk factors, implementing protocols, avoiding traditional sliding scale regimes, and changing unsafe prescribing behaviors are ways to avoid severe hypoglycemic events. Reviving hypoglycemic signs and symptoms with the entire inpatient team, including patients and their significant others, allows for early detection and treatment. Establishing and publishing a simple treatment protocol affords prompt action to appropriately treat various stages of hypoglycemia. Thank you for your patience hearing.
Thank you, Dr. That was indeed a very clear presentation, a wonderful talk, and you made the slides look so simple and so that everyone, even a first MBBS student, can understand the whole concept of hypoglycemia. So it was as simple as that. Thank you once again for that wonderful lecture. So we are moving into the panel discussion without wasting much of time. For the panel discussion, I invite two more panelists. We have Dr. Sumesh Raj, who is the Professor of Medicine at Gokulam Medical College, and Dr. Arun Shankar, who is the diabetologist and director of Jyotidev's diabetes centers across Kerala. And we also request Dr. Aravinda and Dr. Sunil to join the discussion. So I will start off the discussion with Dr. Sumesh. Sir, the question is on diabetic ketoacidosis. So initially itself, Dr. Vijay Kumar sir had said that DKA is becoming less common nowadays. So how is it in your practice? I am asking with respect to type 2 diabetes, whether you are seeing it less frequently. And with type 1 diabetes, even the international data show that less number of people with type 1 diabetes now present with DKA. The presentation symptoms of DKA has changed over the decades. So your personal experience on that.
Yes, Dr. Prashant. Again, the incidence of diabetic ketoacidosis in type 2 diabetes is on a decreasing trend. Already it was less common, and now we are seeing lesser cases. And if you are seeing either a patient with a single ketone plus in urine, it is most often due to associated starvation or due to dehydration that is seen in diabetic ketoacidosis. Though in many cases of diabetic ketoacidosis, even it is less common in type 1 diabetes. But we see more of hyperosmolar state in type 2 diabetes. Maybe the reason is more of obesity, more of insulin resistance, and for a decade to occur, there will be a related deficiency of insulin. So, as Dr. Vijay Kumar told initially, the occurrence of diabetic ketosis type 2 diabetes is already very low. And again, most skin vendors and rarely vendors associated with stress. That too, many times may be a hyperosmolar state associated with a single plus ketone in urine, may be due to an associated scar. Overall, it is anyway less in a type 2 diabetes.
Thank you, Dr. Sumesh. My next question is to Dr. Arun Shankar. Dr. Arun, as you all know, Dr. Arun is coming from the diabetes technology capital of Kerala. And my question is directly related to the use of technology. I have two questions. The first is on the use of remote monitoring and telemedicine in preventing diabetic complications. Your center has been using telemedicine and the remote monitoring for almost more than 2 decades, if I am right. So how you have been able to prevent the acute complications, both hypoglycemia and hyperglycemia?
Thank you, Dr. Prashant. I would like to take this opportunity to congratulate Dr. Prashant Shankar for coordinating this Crossroads of RSSDI Kerala chapter, and thanks to entire executive committee members for giving me an opportunity. I think the two speakers were very clear about the topic on the acute complications of diabetes, and they were stressing the importance of how to prevent both the hyperglycemic crisis and the severe one, which is hypoglycemia. So from the day one, I think we have to educate and make the patient and bystander aware of the situation of both these crises, that let it be the hyperglycemia or hypoglycemia happening both in type 1 and type 2 diabetes patients. So as you clearly said, at our center, we are practicing telemedicine based management in diabetes care, which was started way back in 1998 itself. And with the usage of telemedicine and remote monitoring, we could show that the patients were able to control hyperglycemia without significant episodes of hypoglycemia. And at the same time, they could reduce the cost of treatment as well while managing diabetes. So I think the point which was stressed by Sunil Prashop sir, the hyperglycemic crisis situation, the risk factors, mainly infection or any other stressful situation happening, which can result in hyperglycemia crisis, then the patients are supposed to manage diabetes or hyperglycemia with regular monitoring of blood glucose. Let it be type 1 or type 2. We have to educate them to have a better or frequent monitoring of blood glucose, and with the use of telemedicine or remote monitoring during this crisis situation of COVID as well, we could, many of us were using this technology, including telemedicines, to manage our patients' glycemic status during those crisis situations. So many times patients are forced to monitor blood sugar frequently. Depending on individual patient profile, you are supposed to ask the patient to monitor blood sugar, and with the help of your team, let it be a diabetes nurse or diabetes educator along with you, a diabetologist or the treating physician, they can have a better control on your patient's blood sugar without ending up with hyperglycemia, as well as avoiding hypoglycemia. During the second session, which was clearly mentioned by Dr. Aravinda with regard to hypoglycemia, you have to prevent hypoglycemia, make the patient aware of the situation that while dealing with diet, excessive exercise part, which many patients, like one of our type 1 patient who was very keen and eager to control blood sugar only with exercise. You can imagine how that patient can end up with hypoglycemia. The same situation happened with that patient, and she was doing the treadmill regularly for 2 and 3 hours continuously without taking the mid-daytime bolus insulin. She wanted to avoid insulin bolusing. So, and she ended with hypoglycemia. She had seizures, and now she is planning for insulin pump deployment. So the second part of your question, which is again focusing or stressing on the importance of technology being incorporated in diabetes management. Definitely, you have all those advancement in technology being incorporated in diabetes management, including the connected devices, the sensors. As you all very well know, the usage of continuous glucose monitoring had helped us a lot in knowing in detail of the blood glycemic variability, where we are now targeting on time in target, time in range, the addressing the glycemic variability part. So the connected glucometers, connected sensors, that is in the sensors, we have the continuous glucose monitoring, the real-time monitors being used, the flash glucose monitoring, where the patients can have a look on the glycemic variability with regard to the diet part, exercise, and all those medication, how is going to act on your blood sugar on better control of blood glucose level. So with the usage of these new technologies, definitely it will be a type 1 diabetes or a type 2 with brittle diabetes, they can have a better control. And moving on to continuous subcutaneous insulin infusion, the newer insulin pump which we are using right now, that is the 780G with the sensor detecting the hypoglycemia prior to the occurrence, and of course after the hypoglycemia being corrected when the blood glucose going high, the automatic delivery of adjustment of basal insulin being helping in the patients to have a better flat glycemic status, to have a better glycemic control, so that we can prevent the hyperglycemic crisis and the hypoglycemia happening in those brittle diabetes, including type 1 diabetes patients.
Thank you, Arun, for that detailed explanation. You have answered 2 questions in one sitting. And the next question is again to Dr. Sunil Prashop. Sunil sir, there is an entity known as the ketosis-prone type 2 diabetes. It's something which is written in the literature. Have you encountered such cases? How are they managed? And what do you want to say about this ketosis-prone diabetes? It's not that uncommon.
It's Prasad, actually, during my talk itself, I told it's very clear that DK is characteristically seen in type 1 diabetic patients. And in HHS, we do see type 2 diabetes. That is basically due to the absolute insulin deficiency in DK. What happens in type 2 diabetic patients, in type 2 diabetes over a period of time, 20, 30 years, some of these type 2 diabetic patients may behave like a type 1 diabetic patient. In such cases, when their insulin reserve is very, very reduced, such patients can have diabetic ketoacidosis. But I think the point that you are alluding to is the one which is there in the literature saying that ketosis-prone type 2 diabetes. I think what we are alluding is the African American and Hispanic population. There is a group of population, and what is being seen is the young male population, less than 40 years, very high BMI. They newly diagnosed, they do have family history of diabetes, and they are diagnosed acutely with the diabetes, newly diagnosed type 2 diabetes with a very high A1C, and they are ketosis prone. They often present with ketosis. The thing is that after the initial treatment, many of them do well with OHAs. The reason, actually, I don't know there is what is the exact reason, because most of these patients do well with OHAs after that. So that is a very specific population which is being mentioned in the literature, African American and Hispanic population. The exact reason, I don't know.
Thank you, sir, for that explanation on ketosis-prone type 2 diabetes. I would like to ask the next question to Dr. Sumesh Raj. Sir, your opinion on the use of the point of care keto which are being currently used, something which I have been using frequently for the last few years. We have found it very, very useful, not only in type 1 diabetic patients, but also in inpatient management when we are monitoring or following up patients with the DK or an HHS. The point of care ketone meter seem to be very useful. Your comments on that?
Yeah, point of care ketone meters are now becoming more common. We have a couple of ketone meters which detect both blood glucose and ketones in our ICU setup. And many times, though these are used for measuring the blood glucose, we can easily change the port and go on for looking for the ketone bodies also. And but the routine monitoring again goes with urine ketones. And if any doubt, I have sent several patients for serum acetone values also. The point of care ketone meters, so many of my patients who are obese and following a keto diet have this in their home also, and they have started doing this. And whenever they try to get in a target of between 1.5 and 3, and I have a couple of patients who went above 3 and went on to a medical emergency. They immediately started going. That is one point, but it is not good for self-monitoring like a blood glucose, but it is ideal in a hospital setting. And should have a trained personnel, especially in most of the ICUs and corporate and private hospitals. The trained personnel, they are trained to look for the ketone bodies, because urine ketones can many times be mistaken. A single plus will be there. This is an ideal one. And if it is used, the 2 or 3 companies that have brought it out, also you are getting it below 2,000 rupees. Yeah, but the strip is costly. And how frequently we monitor, these are the issues. Acute. There are no any guidelines or consensus for how frequent you have to monitor a blood ketone. That is the only thing that is. But we are using it though less frequent. In our ICU, I will specifically write in the orders to look for blood ketones, serially ketone. Because we can't just say how frequent. That is not true. But it is a good one, and the more frequently you become accustomed to, and you find it very useful.
Thank you, sir. Yes, the most important thing is that blood ketone meters measure beta hydroxybutyrate, and the urine we are measuring acetone. So there can be false negative and false positive values.
Yeah,
and
previously serum also we could only measure beta hydroxybutyrate because acetone is volatile. Now our lab measures serum acetone, but ketone meter can measure only beta hydroxybutyrate. But the serum levels for acetone and beta hydroxybutyrate both are the same.
Dr. Aravinda, one question on euglycemic decay acidosis with the increased use of SGLT2 inhibitors. Have you encountered number of patients, even though it is mentioned in the literature, the actual incidence seems to be very low. Your personal experience on that?
So personally, if you take the incidence is very, very less. One patient, I had got a referral from an hospital in the ICU where the patient was admitted for a major surgery, major abdominal surgery. They had done a surgery for evaluation of cause of pain abdomen or so, something like that, major surgery only. So the patient suddenly after the surgery, patient became ill and altered sensorium was there and not responding very well. Some like that, the reference was there to see the sugar status because sugar was fairly under control like that. So when I went there and took the history, then we came to know the patient was on SGLT2 inhibitor, which was not stopped. So that was the reason for you take it as euglycemic DKA, and appropriate measures was taken after a very prolonged period. With a great difficulty, the patient did survive. That is the important thing. So however, in my routine clinical practice, the rate of euglycemic diabetic acidosis is very, very less. What we should generally understand is what happens in euglycemic diabetic ketoacidosis is there will be a lowering of insulin production, and there is an increase in glucagon secretion, which generally promotes a shift of glucose to fat metabolism, and that stimulates the ketogenesis. This is what generally happens. The most important thing is we can generally prevent this. We should select the appropriate patient, and appropriate measures has to be taken. For example, if any of you have got a referral for physician fitness for the surgery or major surgery or elective surgery, make sure that SGLT2 inhibitors is stopped at least 24 hours. I generally do it 3 days before the surgery, but at least 24 hours is needed, so that to prevent euglycemic euglycemic decay. The other causes, like we generally tend to forget, is the pregnancy. Pregnancy is one condition where the patient can go for euglycemic decay. That is, may not be related to SGLT2 inhibitors. There is one other condition. And if the person is having prolonged fasting, like in India, our culture, there are so many conditions that we do fasting, whether it may be Ekadashi or where there may be Ramazan, where there is prolonged fasting. So at that time also, there is a chances of euglycemic decay is noted. So the most important thing we should always remember is euglycemic decay is definitely a predictable, and it can be a detectable and a preventable safety concern of SGLT2 inhibitor. That is what I can say.
Thank you, sir, for that clear-cut answer. Next question is to Dr. Sunil once again. Sir, I just wanted to highlight one article which was published in JAMA a couple of months ago, which used subcutaneous insulin protocol successfully in patients with DK. It was a multi-center study where subcu insulin was used in patients, and they found that the outcome was good and hypoglycemia was less. So I'm asking this question because practically this might be required in busy settings, in settings with limited ICU facilities. This is something which can be used, or which could be used in the future. Your thoughts on that, especially in the resource limited settings?
It's in a way you are true, Prashant, that in a resource limited settings, one may think in such direction that why can't we use sub-Q insulin? But conventionally, I don't think that is right, because basically why we are giving IV insulin is to address the acidosis. IV insulin basically addresses the acidosis. There is when we are giving infusion, there is a steady state which is being maintained. And if you are giving subcutaneous insulin, the steady state may not be there. It takes some time. So conventionally, to address the acidosis, to inhibit the ketosis, actually IV insulin is a must. That is what being seen in many of the studies. But of course, as you said, in a resource limited setting, if there is no other way, of course, you may think of a subcutaneous insulin. But conventionally, many are for IV insulin only, especially in DK. Balashans are at some point to say. Yes, sir.
Can I add one more point, Dr.
Yes,
Sunil?
yes, sir. Yes, sir.
Actually, there was a studies on subcutaneous as well as intramuscular injection of insulin DKA. In addition to what Sulas mentioned, just mentioned that in a severely dehydrated patient, subcutaneous insulin has got an erratic absorption. As such, the efficacy may not be as we are giving in. I think there are a lot of articles, and I came to read a few articles.
True,
but the same point was being looked into in the past. So I think
absolutely that is true, sir.
Yeah, very severe, because we have to supplement 3 to 6 liters of fluid in certain scenario. So dehydrated, and if it is not properly being absorbed, and how many times and how much you prick, and that all is another issue which you have to address.
Yes.
Okay, that is what I would.
Thank you, sir. I would like to continue with Dr. Sunil Prashov with one question which is asked by Dr. Jyoti Prakash. Again, Jyoti Prakash is the physician who is working in our hospital. He's asking whether normal saline is still the ideal fluid in DKA. And the next question is, metformin is actually contraindicated in hospitalized patients.
Yes, actually, normal saline is the treatment of choice. IV fluid, the treatment of choice for us, the first choice of IV fluids. But I think, as I have included in my slide, always better you look the sodium status. If it is the sodium is low, definitely normal saline. And if the sodium is, in a case of HHS, if the sodium is normal, the corrected sodium is normal or high, then half normal saline will be the treatment choice. I think why Jyoti sir might be asking that question, maybe there was some concern of hyperchloremic acidosis. I think that may be the reason. But conventionally, in all guidelines, all treatment, still normal saline is the treatment of choice. Regarding the second question, metformin, of course, we cannot give a blanket statement that metformin cannot be used in hospitalized patients. We may have to use metformin in hospitalized patients, but in a critical care setting, in a critical setup, I think it's better to avoid metformin. We always go for the conventional insulin therapy in a critical care setting. Other than that, we cannot say if it is not a critical care patient, definitely we can use metformin if it is not contraindicated.
Another question, we'll wind up the session with a couple of questions. One last question to Dr. Arun Shankar. We know that Diabetes Crossroads is not a sponsored symposium, but still I have to ask this question. With the use of the advent of the newer insulins like the U300 Glargine and the Degludec, which is there, and the newer rapid acting analogs, has the incidence of hypoglycemia come down, or has it become easier to manage patients at risk of hypoglycemia? You might be having experience with many hundreds of patients on the newer drugs. So your experience on that.
Thank you, Dr. Prashant. Again, while managing diabetes, you are following so many protocol or guidelines. We do have RSSDI guidelines for initiating and titrating insulins as well. So depending on your patient profile, you are going to select the molecule. That is true. But when you are selecting the molecule for a particular patient, as an initiation part, definitely you are going to start with basal insulin. And if the sugars are not getting controlled with that basal insulin, definitely you are forced to go for intensification of insulin. So from the basal, sometimes you will be moving on to basal bolus regimen, or sometimes you will be shifting to biphasic insulin regimen. So I'll share one experience which I had today, because one of our old patients who visited us, a 78-year-old lady, she was doing very well with basal insulin and added on oral agents, including gliptin and metformin. And she got COVID infection in between, and she lost follow-up. And at that time, definitely during an infective time, the blood sugars won't be getting controlled with the safer or the less potent agents which we are discussing right now. She was forced to modify her treatment, and doctor changed to conventional biphasic agent. And after that, after infection, she had frequent episodes of hypoglycemia. So again, we had to go back to the initial prescription with basal insulin and minimal dosage of OHS. So that was the experience with the conventional insulins. So definitely you are able, or you can have a selection of all those choices available, including all those insulin combinations available for diabetes management. But definitely the newer, safer analog agents have shown that the basal insulin, including the one which you had mentioned, the glargine, let it be U100 or 300, and the degludec, we can have a better glycemic control where the patients are having an advantage of having better flexibility with the usage of that molecule, with less risk for going for hypoglycemia, but at the same time attaining better glycemic control with better time in range, let it be the U300 as well as the degludec. What we have seen from the initial part, where we were also part of type 1 diabetes clinical trial with degludec. From that time itself, we have seen that there is less risk for going for hypoglycemia, both the overall hypoglycemia as well as the nocturnal hypoglycemia. And patients are comfortable with the analog newer agents. And I do agree that the cost factor, you have to think of that, but patients are having a better glycemic control with better quality of life, where you can avoid, you can prevent the severe hypoglycemic episodes, which can end up with the total uncontrolled glycemic status among your patients.
One question related to the same to Dr. Aravinda regarding the use of sulfonylureas. You cannot skip a talk on hypoglycemia without mentioning on sulfonylureas. So what is the current status of sulfonylurea? Should we use it, or should we stop using it, or should we use it at reduced doses? What do you do in your clinical practice?
Those, with the advent of all these SGLT2 inhibitors and DPP4 inhibitors and all those things, the dilemma is always with the sulfonylureas. But we should all agree one thing with sulfonylureas. This is one of the drugs which has got a potent reduction in HbA1c after insulin. So keeping this in mind, the sulfonylurea is not going to go in our clinical practice. I do definitely do regularly use this, but the pressure comes from so many sides saying that now the generic generic SGLT2 inhibitor, generic DPP4 inhibitors, which is cost effective, is there. You can directly go with this drug. But the amount of reduction, if you see there, it is only 0.7 to 0.8. But if you want a robust reduction with HbA1c, the sulfonylurea is going to stay. But only thing, the chance of hypoglycemia is definitely there, but you are selecting the appropriate patient and using at the appropriate time is definitely is a definite option. We can always start with a slow dosage, low dosage only, because definitely we do that. Starting, if you take glimepiride, it will be like 1 milligram, or gliclazide from 30 milligrams low. So gradually we titrate depending upon the response what we get. So ultimately, what I say to conclude with sulfonylurea is, it is like a old wine in a new bottle. So it will definitely going to stay.
Sir, Balashran sir wants to add something to that.
Yeah, actually, now the recent debate on the use of sulfonylurea, if you look into that, the pharmacology and the action of sulfonylurea, it is a secretagogue. And the UKPDS has already mentioned that when a patient has got a diabetes, 50% of the beta cell is already destroyed, and we have got only limited reserve of beta cells in the future, where we can use any drugs for a efficacious management. But altogether, avoid the secretagogue like sulfonylurea, we have to focus the point that in a newly onset diabetes patient where adequate reserve of beta cell and a secretagogue in a low dose will be most effective in stimulating the insulin secretion. And if you look at the other pharmacological aspect of a gliptin or a SGLT other, it has got another different mechanism of action. So we have to take into this factor in consideration which patient we should add a sulfonylurea. In a newly onset, where a patient has got a young onset diabetes patient adequate reserve, I think it is a most cost effective that at least we may be able to use it for 3 or 4 years. And the diabetes, a long duration diabetes, already we expect there is no beta cell reserve. Probably you have to limit the use of sulfonylurea rather than the blanket rejection of sulfonylurea, because there are so many new agents. I think this may not be a good thing. You have to take into this factor of the mechanism of action and whether the reserve is in the patient is there, and we have to be very selective in giving sulfonylurea to the patient. So there are several patients new onset, it is indicated at least for 3-4 years. Okay.
Thank you, sir. Thank you. I think shall we?
Yeah.
I think we have last time we had a good discussion. Yes, sir. Over to you.
Yeah.
Hello.
Because of
Yeah.
the interest, the keen interest evinced by the speakers and the topic as well, I think probably the scheduled time has actually passed we are overshot by around 15 minutes. But anyway, I think around 50 participants still kept on listening to all you discussing, and we had around nearly 70 plus participants at almost every time throughout the meeting. It's an excellent deliberation. All the speakers as well as the panelists done wonderfully well. I think probably we'll continue the same spate of discussions and lectures in the future upcoming events as well. With this, I think I would thank all the speakers, especially our guest speaker and our own speaker, both of them, for wonderful presentations. And all the participants also, I would like to thank from the depth of my heart that you took time out at this weekday to come and be with us throughout for almost more than 1.5 hours. So I would also request, along with this thing, to all those who are here now in the panel, in the forum, that please during the next time circulate the invitations for this sort of meetings to more and more colleagues and encourage them to participate. Let us have more beneficiaries. That is, more people, more doctors dealing with diabetes get benefited this sort of basic science discussions and debates during our monthly crossroads. And once more, thanking you all. I think probably we'll call it a stop here. Thanks.